Hello and welcome to CLP's webcast, Optimizing the Anti-XA Assay, the Laboratory's Perspective, sponsored by Siemens Healthineers. I'm Chris Wolski, CLP's Director of Business Intelligence, and I'll be the moderator for today's presentation. Now, at the conclusion of today's presentation, we will have a short Q&A with the webinar's presenter, Dr. John Mitzios. Please, at any time, feel free to submit a question via the Q&A box on your screen. Those questions that aren't answered will be addressed directly by Dr. Mitzios and the Siemens Healthineers team after the conclusion of the webinar. And you can give us those questions at any time during the presentation and during the Q&A session. Today's webcast is being recorded, and you will receive an email tomorrow with a link to the recording. It will also be available for new registrants to watch on GoToWebinar for the next 3 months. So if you know any colleagues who have missed out, please let them know. It's now my pleasure to introduce you to today's presenter, Dr. John Mitzios. Dr. Mitzios is a medical sciences partner in the medical affairs team at Siemens Healthineers. His primary research interest throughout his education and training has been in coagulation, with an emphasis on platelet function and biology. And previously, Dr. Mitzios was on the faculty at the Weill Cornell University School of Medicine as an assistant professor of pathology and laboratory medicine, and as an assistant attending clinical chemist at New York Presbyterian Hospital. In addition, Dr. Mitzios has served as an assistant director of the Special Coagulation Laboratory at BioReference Laboratories, overseeing the day-to-day activities of the lab and signing out clinical hemostasis cases. Sorry about that. So without further delay, I'll hand the baton off to Dr. Mitzios. So take it away, Dr. Mitzios.
Well, thank you for that introduction. And today we're going to be talking about optimizing the anti-10A assay, a laboratory's perspective on heparin monitoring and DOAC testing. So there you go. So with any presentation, I always like to start off with some learning objectives. So today we're going to describe some of the anticoagulant effects of the direct oral anticoagulants, including those of heparin as well. We're going to explain the methods used to determine, for example, apixaban concentration or heparin concentration as well. We're going to discuss some of the limitations of the anti-10A assay, as we're going to also discuss a little bit of how would you formulate an approach for the conversion or to convince or utilizing the anti-10A assay in your clinical practice, and really how to start that conversation with your clinicians and pharmacy. So I've structured my talk into two buckets. One is background, which may be review for many folks, and of course, focusing then on anti-10A testing as well as anticoagulation. So let's start off with a little bit of background. So we know that coagulation is really all about balance, right? Where we have this nice balance between both thrombosis and fibrinolysis. So if the scales are tipped in favor of fibrinolysis, of course, there's a higher risk for bleeding. If the scales are tipped in the opposite direction, there's a higher risk for thrombosis. So how does a body really balance these between thrombosis and fibrinolysis? So about 100 years ago, Dr. Virchow described this virtuous triad of thrombosis, which is really encompassing of three primary characteristics: endothelial dysfunction, hypercoagulability, as well as the stasis of blood flow. So when we think of endothelial dysfunction, we really think about anything that would disrupt the endothelial layer. So for example, a virus-induced endotheliitis, some type of immune-mediated activation of the endothelial cells, either via complement system or even through a cytokine storm, as we saw in the COVID-19 associated coagulopathy that we saw in patients who had COVID-19. Anything results in this kind of enhanced vascular permeability. This translates into kind of a more of a hypercoagulable state by recruiting platelets to the area of injury, resulting in platelet activation, the subsequent thrombin formation, as well as neutrophil extracellular trap or netosis, resulting in also fibrinolytic shutdown. So anything that's now disrupting that balance. Of course, that leads to that stasis of blood flow, or for example, any type of microvascular occlusions, or even pulmonary microthrombi, anything that's preventing further blood flow. Now, when we think of coagulation in general, we think of it into three distinct stages. The first is primary hemostasis, where we have that initial interaction of platelets to the damaged endothelial layer, where we have adhesion and subsequent platelet aggregation, as well as secondary hemostasis, where we have the activation of our clotting factors and subsequent fibrin formation, and of course, tertiary hemostasis, where we have fibrin cross-linking and fibrinolysis, and really the formation of that stable clot. So within the processes of secondary hemostasis, we really have the activation of our coagulation cascade. Well, of course, this is a very simplistic version of the coagulation cascade, but you can see it's composed of obviously two distinct pathways, the extrinsic pathway as well as the intrinsic pathway, feeding into the common pathway, which results in the formation of, or the activation of thrombin and the subsequent clot formation. From a fibrinolytic perspective, we have the activation of plasminogen via tissue plasminogen activate to that of plasmin, and the formation and the subsequent fibrinolytic process, resulting in the formation of fibrin degradation products, as probably one of the most well-known markers of coagulation in D-dimer. In addition, we have a number of natural anticoagulants, such as protein C and protein S, and of course, antithrombin, which will actually play an integral role in today's conversation, especially as it interacts with heparin to facilitate its anticoagulant properties. So all of these systems are in place to maintain that proper balance. However, in certain situations, especially when the scales are tipped in favor of thrombosis, there's a higher risk for thrombosis. So fortunately, today we have a number of processes or anticoagulants or antiplatelets in place that allows us to mitigate or control those adverse effects or results associated with those thrombotic events. We think of antiplatelet agents that can be administered. There are specific P2Y12 inhibitors that can be given that specifically target receptors on the platelets, mitigating or minimizing the responsiveness to ADP. Aspirin is another good antiplatelet whereby it inhibits COX and therefore the administration of the generation of thromboxane A2. But we also have a number of anticoagulants which really target the coagulation cascade. Unfractionated and low molecular heparin are good examples of these anticoagulants which target not only factor 10, but also factor 2. But we also have new anticoagulants or new oral anticoagulants like direct thrombin inhibitors like bivalirudin and dabigatran, and of course, direct anti-10A inhibitors like rivaroxaban, apixaban, and edoxaban. So now let's take a step back and really focus in on anticoagulation and anti-10A testing and the clinical utility of anti-10A testing specifically. When we think of the timeline of anticoagulant approvals, we kind of think of, there's been a kind of a large gap, right? When we think of anticoagulation specifically. In the 1930s, unfractionated heparin was approved. In 1954, warfarin came along as the first FDA approval of an oral anticoagulant. In 1993, we have the approval of a low molecular weight heparin, in this case, enoxaparin. And then, of course, in the 2010, 2017 timeframe, those 7 years, we really had this big or large approval of various anticoagulants like dabigatran, rivaroxaban, apixaban, and edoxaban. And of course, as we move now into the 2025, 2026, and so on, we will see more anticoagulants that are coming out that are going to be targeting different aspects of the coagulation cascade, perhaps even looking at targeting factor 11 specifically. But for the purposes of today's talk, we're really going to focus in on heparin and the DOACs. When we look at heparin and warfarin specifically, warfarin targets your vitamin K dependent factors such as factors 2, 7, 9, and 10. Or we look at heparin, which targets your factor 10 and factor 2, depending on the type of heparin that's being used. So we have two versions, unfractionated and, of course, low molecular heparin. And, of course, we have those direct thrombin inhibitors like edoxaban and bivalirudin that also target the factor 10 or factor 2 or 2 inhibitors. Initially, if you think of the kind of the clinical background for both warfarin and heparin, of course, they were given to prevent any further clotting to happen in these patients that are higher risk for thrombosis. So we focus on warfarin. It's a vitamin K antagonist targeting specifically those factors that interfere, or those factors that are vitamin K dependent factors, such as factors 2, 7, 9, and 10, and it really prevents the synthesis of these proteins to be formed. Therefore, it reduces its functionality of these clotting factors. And the way for us to really assess the clinical or monitor these patients on whether or not they're properly anticoagulated is really using the PT-INR. Of course, we're not going to be talking today about the PT-INR. That could be an entirely separate conversation, but we're really going to focus in on the clinical utility of heparins and the DOACs, specifically that how do we assess these patients and how do we look at the clinical, how do we see if these patients are properly anticoagulated. So if we look at heparin specifically, we know that it can be composed of unfractionated and low molecular heparin, and it facilitates and allows the forming of a complex between antithrombin and therefore the subsequent inhibition of factor 10A and factor 2A. So if we look at heparin, there's a unique characteristic on heparin that basically there is this antithrombin pentasaccharide binding site that's found on the heparin molecule, which allows and facilitates the binding or that formation of that complex that I just previously mentioned. So when we look at the two unfractionated heparin and low molecular heparin, of course, the names obviously denote their major differences. It's the molecular weight or the size of the anticoagulants. But what's interesting is you can see in the slides that pentasaccharide sequence is preserved in both unfractionated and low molecular heparin. Well, if you look at UFH, which does require routine monitoring, it has more of a variable dose response, and typically monitoring is required in pretty much all patients, in which the assays of choice are really your PTT and your anti-10A assay. Whereas LMWH does not require routine monitoring, has a more of a predictable dose response, and in a select patients do require monitorings. For example, patients who have some type of renal dysfunction, and the assay of choice is really your anti-10A assay. But how does heparin really work? If you think about it, the way that both UFH and LMWH operate is that pentasaccharide sequence allows it to form that complex with antithrombin and really allows for the accelerated inhibition of both factor 2A and 10A. Interestingly, though, when you think of low molecular heparin, it has a more of a blunted, quote unquote, blunted response when it comes to 2A. So when we look at the anticoagulant nature, unfractionated heparin has really a one-to-one stoichiometry for between both factor 2A and factor 10A. Whereas at LMWH, there's more of an anticoagulant effect with respect to anti-10A or factor 10A than there is with 2A. The half-lives for both unfractionated and low molecular heparin are about 30 minutes to 2 hours for UFH and about 3 to 4 hours for LMWH. But what's also important, we want to think about how do we reverse the effects of unfractionated heparin? Well, typically protamine is given to reverse the anticoagulant effects. With respect to unfractionated heparin, it's possible, but with respect to LMWH, it's possible, but yet there's incomplete reversal. And this plays an important role, especially when we want to calculate the protamine reversal or how much protamine we would have to give to the patient and where the anti-10A assay actually does play an important role. When we think of our new oral anticoagulants, such as rivaroxaban, apixaban, and edoxaban, you can see these are direct factor 10A inhibitors, specifically targeting that factor 10A, as well as we can have our anti-2A or direct thrombin inhibitors, which target factor 2A. These are those new oral anticoagulants that are available. And when we kind of do a quick comparison between these new oral anticoagulants, such as dabigatran and rivaroxaban, apixaban, and edoxaban, I also want to point out that if you look at the the names of the anticoagulants, specifically the 10A inhibitors, you can see that in all of them, they all end in XABAN, indicating that they're 10A inhibitors. But what were the advantages and what was the rationale for creating or developing these new oral anticoagulants? Well, really, there was essentially no dietary restrictions, right? If you think of warfarin, there's more dietary restrictions. There's a lot more more restrictions with respect to types of foods that we can eat. Warfarin, for example, does require routine blood monitoring to ensure that your INR falls within that therapeutic window. Whereas in DOACs, there's really no established therapeutic ranges. There are established peak and trough values, but there's not an established therapeutic range. There are multiple drug interactions that could potentially reduce the anticoagulant effect in the context of warfarin therapy. For example, there are a number of medications, antibiotics or antidepressants, that could potentially interfere with the anticoagulant effects, especially as our patient population gets older and they're taking more and more medication. You can see those adverse effects perhaps on your warfarin therapy, where your INR can be significantly elevated. However, there's no drug interactions that reduce the anticoagulant effect as yet described by the clinical studies that have been performed. Whereas in example of with respect to warfarin, there's a higher incidence of bleeding, right? Because it sometimes can be very challenging to maintain that INR within that therapeutic window. Whereas in this, there's less bleeding indices in clinical studies. So there are clearly some advantages to using our patients being treated with these new oral anticoagulants. Here, we just see the structural representation of the DOACs. We have our direct anti-2A inhibitors, dabigatran, and of course, we have our factor 10A inhibitors, rivaroxaban, apixaban, and edoxaban. Looking for the clinical indications for the 4 anticoagulants that are on the screen, you can see what the target enzyme is, right? Dabigatran is that direct thrombin inhibitor, while the other ones are direct anti-10A inhibitors. We also have the registered trade names that are in the US as well as in the European Union, as well as perhaps some of those clinical indications in which these medications are approved for. Apixaban right now, if I remember correctly, is probably one of the most well-known or mostly prescribed anticoagulant. And you can see that it has a diverse list of clinical indications that it can be used for, such ranging from thrombosis prophylaxis in total hip or knee replacement to that of prevention of stroke and atrial fibrillation, as well as the treatment of acute DVTs and PEs. Interestingly, when we look at the pharmacological properties of the 4 anticoagulants that are on the screen, we can see that, again, the target. We can also see the respective half-lives, the renal elimination percent. You can see dabigatran is primarily renally eliminated, whereas rivaroxaban, apixaban, and edoxaban, there's a broad distribution in which apixaban is probably one of the least renally eliminated drugs. Interestingly, though, there are antidotes that are available. Adarasuzumab is available for dabigatran, as well as dexamethasone alpha is available for the anti-10A inhibitors. And this is actually important, especially when we talk about monitoring, because the clinical effectiveness of many of these antidotes are appropriate at specific concentrations that I'll talk about in the coming slides. And that's why understanding and being able to assess the presence or the amount of drug on board can be clinically useful, especially if an antidote is indeed needed. But I also want to make this quick distinction between monitoring and measurement, right? Now, these can be used synonymously, but in the context of anticoagulant therapy, I think it is important to make a distinction. Monitoring is really assessing and knowing that there's a therapeutic range associated with that particular anticoagulant that's being measured. For example, if we look at warfarin, we know that the INR, for example, is a target INR of 2 to 3. Or if we're looking at unfractionated heparin, we know that a target heparin therapy is between 0.3 and 0.7 units per ml. And measurement is really giving us a quantity, right? So we don't really have an established therapeutic range, but we need a value to determine whether or not, in this particular case for the DOACs, the administration of the antidote is indeed appropriate. But when we think of monitoring, for example, especially in the context of heparin therapy, there are a number of instances where we do need to monitor some patients to ensure that they're properly anticoagulated to prevent any unnecessary thrombotic events. For example, in high-risk pregnancies, being able to assess the patient to ensure that they're properly anticoagulated during their pregnancy. Children, of course, because of differences in body weight, differences in ages, and so on, it does promote and it does allow us to get that therapeutic concentration by giving us that ability to monitor these patients. Patients who have liver disease, right? I mentioned patients who are grossly over or underweight, extremely important to ensure that we're making and we're having the proper anticoagulant effect. Patients who are on a lupus anticoagulant, they're a higher risk for thrombosis, and so therefore these patients need to be monitored to ensure that they're properly anticoagulated to prevent an adverse event. Now, when we think of DOACs, according to the manufacturers, right, monitoring wasn't really needed to adjust any dose, right, because that was one of the quote unquote selling points of these newer or oral anticoagulants, right? You don't need routine monitoring. But sometimes quantification of a concentration may be necessary to facilitate an additional clinical management strategies. For example, administration of an antidote. And there are specific clinical situations that may warrant this measurement of a DOAC. For example, in a patient who has accumulation due to some impaired renal function, we saw that some of these medications can be renally cleared. So dabigatran, for example, is a good example because it's 80% of it's renally cleared. So being able to quantify, saying, well, am I getting enough of this? Is this anticoagulant being retained? The same thing applies with rivaroxaban. What happens in an invasive emergency intervention? Well, we need to be able to assess whether we need to administer an antidote or not to these patients who are coming to the ED, unclear as to what their anticoagulant status is, and allowing us to properly assess and triage these patients appropriately to see whether or not the antidote will be useful in the context of the patient's anticoagulant status. Acute bleeding for unknown cause. Depending on where we're taking the blood sample, is it at a peak or a trough? Knowing that the concentration is within that expected range. But that also is very challenging just because there's a lot of inter and intra variability with respect to patient's responsiveness and to the patient's concentrations for both peak and trough. And I'll show that in the next few slides when we see that there's a tremendous amount of variability for different clinical indications. A compliance perspective, right, to ensure that these patients are properly anticoagulated if there is a concern that they're not being properly anticoagulated. And of course, under and overdosing, right, making sure those extreme changes in body weight, either overweight or underweight, making sure that the anticoagulant that's there is properly is in the appropriate amount to ensure that the patients are properly anticoagulated. When we think of testing, right, we think of the anti-10A testing for heparin. And in the coming slides, I will show some data that kind of supports these comments. Like, for example, you get a smoother dose response curve. The patients are more stable heparin levels during therapy. Fewer blood samples are required to be drawn. Fewer dose adjustments and enhanced clinical outcomes. There are a number of studies that point to the clinical efficacy and the clinical utility of using anti-10A assay as it results to improved clinical outcomes. Now, why is anti-10A a better choice for DOAC testing? Well, of course, we know that the gold standard for DOAC specifically to measure concentrations is using mass spectrometry. But we can think of a mass spec is not readily available in many of our clinical laboratories. So having another assay that we can go to is extremely important to ensure that we're being able to provide that measurement of how much of that anticoagulant. But we know that can we use our, for example, routine assays like your PT and PTT, they're generally not recommended for assessing patients on DOAC because one is their insufficient sensitivity and the linearity for quantitation is significantly altered, impacted. So the more anticoagulant you can have a prolonged PT or PTT, but again, that doesn't directly relate to how much of the anticoagulant is present. And I'll show some of those examples. Different sensitivity of commercial reagents, right? Different impact on routine assays caused by the different DOACs. A good example is what happens if I give a thrombin time and a patient's on dabigatran. Even a trace amount of dabigatran, which is the anti-10A inhibitor, or anti-2A inhibitor, excuse me, will cause a significant prolongation in your your thrombin time. Again, not an adequate assessment of the patient's anticoagulant status. But let's just take a quick step back and just think about APTT and heparin specifically. If you're thinking of your patients being put on heparin therapy, there's a number of things that we have to think about before a patient goes on heparin, because if we're going to be using the APTT to monitor these patients, we have to look at the baseline clinical status or the baseline APTT value specifically. There are a number of clinical indications that can result in increased responsiveness to the PTT as it relates to heparin. For example, patients who have a lupus anticoagulant, you will have a baseline prolongation in your PTT. Patients who have a congenital factor deficiency or even an acquired factor deficiency will have a baseline prolongation in your PT. So therefore, even before heparin is administered, in this case, unfractionated heparin, you could have a prolonged APTT. There are a number of instances, for example, that can have a shortening of a PTT value even before heparin is administered. Those patients would include renal disease patients who have renal dysfunction, pregnancy because of the hyperinflammatory response, as well as patients who have inflammatory conditions could potentially lead to a shortened PTT. So therefore, you have this shorter PTT before even a heparin is administered, therefore altering or perhaps affecting the therapeutic ranges. Whereas anti-10A assay is not affected by these baseline alterations or baseline differences in the patient's PTT status. Let's kind of look at the anti-10A assay. Now, this anti-10A assay can be used for measuring heparin values, both unfractionated and low molecular weight heparin, or it can be used to measure DOAC concentration if you're using specific DOAC calibrated assays. As an example, I'm just going to be using apixaban for this particular example, highlighting how the anti-10A assay would work. Here you have your sample, your patient sample, which contains your anti-10A DOAC. In this case, let's say it's apixaban, and of course you have in your test kit, you have your calcium, your 10A, and of course your chromogenic substrate. There's a number of things that can happen. In this particular case, you can get accelerated inhibition, which results in a decrease in absorbance at 405 nanometers, indicating the presence of apixaban, or non-accelerated or without accelerated inhibition, therefore the absorbance actually increases. So therefore they're inversely proportional. So the higher the absorbance value that you get, the lower the DOAC. But what does this allow us to do? One, it provides us a concentration of apixaban. For example, it also provides, if you're using heparin calibrated anti-10A values, it provides us how much of functional heparin activity that we have that can be potentially used to calculate the reversal of protamine, or the amount of protamine that we would need to give in order to reverse the anticoagulant effects. It could also be calculated or see whether or not the patient is in a concentration of anti-10A, or in this case, apixaban, on whether or not the antidote would truly be effective in reversing the effects of the anticoagulant. Again, here we're using a standard curve that's calibrated specific to the anticoagulant that's being measured, allowing us to assess that. That's why it's also critically important to, whenever we get any type of sample sent to the laboratory, that we know which anticoagulant the patient is on, to ensure that we're using the proper calibrated assay to give them the concentration of the anticoagulant that they need. So one thing that's interesting is that if you look at kind of historically why APTT was recommended as being the assay of choice, it goes back to this paper that was published in 1972, which assessed and looked at patients who are on heparin therapy, specifically unfractionated heparin. And what they noticed is that patients who are in that 1.5 to 2.5 times control value actually had decreased incidence of recurrent thromboembolic diseases. But what's interesting, if you read through the paper, what they point out is they're using a coag analyzer that's no longer used in clinical practice today. So up until today, we have been, and we're still using, many institutions are using the APDT as a therapeutic way of monitoring patients on anti-10A and heparin therapy. However, due to the advances in laboratory hemostasis, we have a more robust assay that's available, in this case, the anti-10A assay, that not only is clinically useful in the context of heparin therapy, unfractionated as well as low molecular, but it's also versatile in its effect to be able to monitor those patients that are on those DOACs, provided that you're using these DOAC calibrated assays. But what's interesting, if you looked at and you kind of do a quick comparison between your anti-10A and APDT, you can see here in this slide that you can see that not all patients are clinically concordant. That is, those patients that are in the kind of the darker color are concordant, and those patients that are in the lighter color are not concordant samples. So you can see there's broad variability. Just imagine how that could potentially affect your clinical decision making if you're the clinician treating these patients with anti-10 or heparin therapy. So when we think about that 1.5 to 2.5 times the upper limit of normal, which is still being used today, we also know that the proper anticoagulant, in this case for unfractionated heparin, as calibrated by protein titration and anti-10A, is around 0.3 to 0.7 when using the anti-10A assay. And I like to do this kind of side-by-side comparison, where here I have my anti-10A and I have the two therapeutic ranges, or the upper and lower limit. And then I have my APDT assay, where I have my normal reference range, and I have what would theoretically be the 1.5 to 2.5 times normal. And we would think that there would be a good correlation between both the 0.3 and the 0.7. But what's interesting is when you look at these studies, they show that when you're looking at that lower end of 0.3, you're seeing about 1.6 to 3.7 times difference. That's a pretty big difference when we're looking at that lower limit. When we're looking at the higher limit of 0.7, you can get from 2.4 all the way up to 6.2 times. So there's a variable sensitivity of heparin when we're looking at the PDT reagent. This is even nicely illustrated when we look at a heparin response curve, or also known as a Brill-Edwards curve. So here on the y-axis, we have our APDT in seconds, and on our x-axis, we have our anti-10A, or therapeutic range. So here I just have a hypothetical example where I have my 0.3 to 0.7 from my unfractionated heparin from my anti-10A, and then I have what would correspond to that 1.5 to 2.5x, 65 and 110 seconds from the APDT. And you can see just by the distribution of the data, there's a broad variability of the data points. But I just want to highlight 3 examples. In this particular example, the patient would be considered to be within the therapeutic range, right? Because it is in the middle or close to that, is well within that therapeutic window of 0.3 to 0.7. But if I'm using the PDT would actually consider to be subtherapeutic. So then it becomes a clinical challenge for the physician. Do I increase the dose, or do I keep the dose as is because my patient is in that therapeutic range? In this particular case, the patient is supratherapeutic, right? Because it's well outside the therapeutic range as defined by the anti-10A assay, that is the 0.3 to 0.7, but it's below the therapeutic window as defined by the PDT, that is below the 65 seconds. So now this is a clinical conundrum. Do we give an additional anticoagulant to the patient? Now, is my patient at a higher risk for thrombosis, or is my patient at a higher risk for bleeding? Because in this particular kind of situation, I have too much anticoagulant, so my patient's actually at a higher risk for bleeding. But if you look at it from the PDT, my patient potentially could be at a higher risk for thrombosis. And I will show some real clinical evidence that shows how these patients and how these samples, or how the PDT versus anti-10A can get you into that therapeutic range much faster. Whereas if I'm looking at this particular example, the patient would be considered to be subtherapeutic, right? Because now it's below that therapeutic window of 0.3 to 0.7 as defined by the anti-10A assay, but it's in that therapeutic window as defined by the PDT. So now again, that conundrum for the clinician is, what do I do? which assay or which assay do I believe? So this is where I talked about that variability, which highlights that extreme variability that we saw in the previous slide, those very wide variations as it results in those low ranges or those low and upper range of your therapeutic range for unfractionated heparin. Just for illustrative purposes here, because we know we can't use the APDT to monitor patients on low molecular heparin, but just for the therapeutic is around 0.6 to 1 as defined by your anti-10A assay. So when we think of a number of pre-analytical, analytical, and biological factors that can affect your anti-10A or can influence your PDT and anti-10A, right? Well, pre-analytic, right, we know that that is probably one of the most, the highest errors that come into the lab. About 70% of those errors come in as pre-analytical, and specifically, you can see here there's less pre-analytical variables that can affect your anti-10A assay versus your PTT. For example, if we're looking at, we're looking at pre-analytics here, we're looking at blood sample, diurnal variations, not really affected by your anti-10A, but your PTT will in fact be affected. Underfilled sample tubes. This is a common problem, I think, in many clinical laboratories, especially when it comes to hemostasis testing, where if we're underfilling, that means the anticoagulant to blood ratio has been severely compromised. So there's more anticoagulant, which would subsequently affect and prolong your APDT assay, could potentially affect your your heparin values. Whereas in this particular case, it's not going to be affecting your anti-10A assay. Analytically, of course, both assays are subject to analytical variations and differences. When we think of biological differences, we want to focus in on, of course, the ones that we mentioned previously. Anything that results in a baseline alteration in your PTT value, either being prolonged as a result of some underlying disease process like liver disease or the presence of a lupus anticoagulant, or anything that could result in a shortened PTT, right? Such as a hyperinflammatory response, pregnancy, those will not be affected by your anti-10A values because your anti-10A will be able to provide you a functional concentration. Of course, I would be remiss if I didn't mention, your effects of hemolysis, icterus, and lipemia on a chromogenic assay, because anti-10A assay is a chromogenic assay. So in grossly hemolyzed specimens, of course, you would need to follow your laboratory procedures to ensure that you're reporting the accurate results. And I also wanted to highlight the antithrombin deficiency. And the reason I highlight that is because we know that heparin functions through antithrombin. So if the patient has a decrease in antithrombin and we're not seeing the anticoagulant effect of heparin that we would want to see, it could be the result of an antithrombin deficiency. So one of the things that we would want to think about is, we may want to measure antithrombin in this patient to ensure that the antithrombin values are where they need to be in order to facilitate the proper anticoagulant for heparin, or the anticoagulant effects of heparin, excuse me. So kind of some general recommendations when you would want to choose the anti-10AA versus the PTT is anyone that has any baseline alterations in your PTT, right? For example, if you're considering the possibility of protamine reversal, being able to have that functional activity value available to calculate the amount of protamine that we need to be given is also important to ensure that we're properly reversing the anticoagulant effects if we need to for these particular patients. So when we kind of think of anti-10A in general, we think of, I kind of put it into three distinct buckets. One is better patient care. Any laboratorian or any of us that work in the clinical laboratories, I think we always have the patient care question in our mind. We want to make sure that the values and the data that we're providing are improving the patient care pathway, allowing the patients to get the right results for our clinicians to make the proper clinical decisions on. So one, these anti-10A assays show smoother dose response curves. The patients get within that therapeutic window much faster. It does provide stable heparin levels, and it leads to improved outcomes. And that second bucket, it does improve workflow, right? Because there's fewer lab tests now that are being run. There's fewer dosing changes that need to be made by pharmacy and our nursing, which ultimately translate into a much more efficient process by allowing those fewer dose changes, and perhaps can even cause or reduce in labor savings because now there's less dosing changes made to these patients. And overall, there's a minimal cost to change. So heparin, or the anti-10A specifically, it does provide you that functional activity value that you can properly assess. There's limited effect due to pre-analytical variables. The only thing that I would really highlight here is that we want to ensure that if a heparin level is asked, irrespective of which assay you're using, you would want to get that sample centrifuged and processed within about 1 hour of blood draw. And that's extremely important because the longer you allow that blood to sit on the plasma to sit on top of those cells, the more platelet factor 4 is released by platelets within their granule contents, minimize or decreasing the heparin activity. So the faster we're able to process it, the better it is for your anti-10A values, and getting a true snapshot in time of the patient's anticoagulant status at the time of blood draw. And there's literature-based therapeutic range. So there's really no need for the lab to establish their own therapeutic ranges. Now, there are some caveats to that, of course, depending on the clinical indication, depending on the reason for the anticoagulation, there may be changes in the therapeutic ranges, but they've been established within the literature. So it may not always be 0.3 to 0.7 for unfractionated heparin, but it may be slightly higher or lower, depending on the anticoagulant that's being given when we talk about heparin and LMWH, or low molecular heparin. This slide just really shows a number of studies that showed the improvement in overall clinical outcomes when we were using the anti-10A assay. So I won't go in this particular, I won't highlight all of these, but I do want to highlight two specific studies. One which was done in an 852-bed hospital system, and one which is done in a smaller medical center, which is 371. And the reason for these patients were slightly different for why they were being hospitalized. But nevertheless, what they want to do is they want to directly compare the APTT versus the anti-10A assay. And they assessed a number of outcomes. They looked at the mean time to therapeutic ranges, and you said when using the anti-10A value, there was a significant improvement. That is, the patients got within that therapeutic window much faster. The tests were within that goal faster when using the anti-10A assay. The number of monitoring tests per 24 hours decreased for both when using the anti-10A assay. Infusion rate changes per 24 hours again decreased. Mean hospital stay decreased in both settings. Of course, one would argue is 6.5 and 5.9 statistically significant, but again, it really, when you're looking at the grand scheme of things, you do see an overall reduction. And I think what's important here is the mortality rate, where there was a significant reduction in mortality rate when using the anti-10A to monitor these patients. So overall, we can see there is an advantage to using anti-10A assay when looking at the overall clinical and overall patient experience, right? Making sure that these patients are, one, discharged safely, and you minimize your hospital stay. But the mortality rate did significantly decrease. I really like this slide as well because it does show you, and I'm more of a pictures guy, so I like this because it does show that your anti-10A allows your patients to get into that therapeutic window much faster than your PTT does. In addition to that, this is a real world heparin response curve, or a real world Brill-Edwards curve. And I like this because it does show and verifies that hypothetical example that I shared. We can see there are a number of patients that would fall into that subtherapeutic category, and there's a number of patients that can go into that supratherapeutic category. But what's interesting is that one of the statements that was made in the paper is this: the discordance between the APTT and the anti-10A in our study was 49%. So close to 50% of your samples were discordant when measuring both APTT and anti-10A. And a notable pattern was that the APT was therapeutic in only 35% of the time, and the anti-10A was also therapeutic. I think that to me is extremely telling, right? And it kind of verifies what that previous slide shows or that previous figure shows where that patients that are being monitored with the anti-10A get into that therapeutic range much faster. And there's a lag period for PTT before it eventually reaches up and meets that of the anti-10A assay. Another study looked at overall blood utilization, especially in the context of patients who have just recently suffered a venous thromboembolic complication, a stroke, or have acute coronary syndromes. And what we can see here, there's an overall reduction in blood RBC transfusions when using the anti-10A assay. So collectively, when we think about what was this triple aim of the study that I just presented, was it improves quality of care, because there's decreased risk of complications among those patients that are hospitalized and are being treated with unfractionated heparin. There's a decrease in the intensity and perhaps the duration of unfractionated treatment because you're getting to that therapeutic window faster and you're allowing those patients to be properly anticoagulated. What's also important, it improves the patient experience. I mean, I'm pretty sure that those in the audience probably don't want to be or want to have a lengthy stay at a hospital. I don't think it's not something that we all strive to do. So of course, the faster that we are discharged from the hospital, safely that is, the better it is for our overall experience and our overall well-being. And of course, there's a cost reduction mechanism associated with that, right? Decreasing the number of our RBC transfusions allows us to save perhaps some money to the hospital system as a whole. When we think of kind of the pros and cons of PTT compared to that of the anti-10, of course, the pros, cheaper. No doubt about it. It's a cheaper assay, right? Because it's more readily available and it's pretty much available 24/7. There's a tremendous amount of literature that has been provided, but there's also provider experience. I think this is where the challenge really lies, is that the providers have been trained in such a way as to think that the PTT is what's going to tell me and what's going to give me the right answer. But you can see there's going to be a lot of variability, and the data does suggest that the anti-10A allows your patients to get into that therapeutic window much faster. There are also a number of cons associated, right? There's a greater number of interferences. We have to take into consideration the pre-analytical, the analytical, as well as the biological factors. Less reliable correlation with heparin level and the therapeutic effect, right? There's a slight delay. There's a little bit of a lag with the APDT compared to that of the anti-10A. And the therapeutic window is really less well defined, right? So we saw that the 1.5 to 2.5 was really from a paper that was published in 1972. And of course, there's been a number of advances that have happened in that laboratory hemostasis space that allows us to properly assess these patients, right? Anti-10A being one, the anti-10A assay being one of them. And of course, there's more lot-to-lot, lab-to-lab variation, and does sometimes require additional correlations, right, with another method. Or even when you're doing a heparin response curve, you want to correlate that with your anti-10A, because you want to have that secondary method to be able to correlate. Where in this case, using the anti-10A, you already have your predefined therapeutic concentrations or ranges. So overall, we see there's an improvement in time, allowing patients to get into that therapeutic window much faster. Accuracy does provide you that functional activity, so if reversal is important, you can give it. Clinical outcomes, it does improve clinical outcomes, right, by decreasing mortality rates. Perhaps it can affect labor by decreasing, let's say, phlebotomy, tech time, nurse time, dosage changes, all those things that could be positively impacted by using a more streamlined approach to anti-10A testing or heparin treatment. And again, overall, goes hand in hand with clinical outcomes is that patient safety, right? Again, improving those patients, decreasing mortality, decreasing bleeding rate when using anti-10A monitoring in patients on heparin. So why do I say all that? Because when we think about now transitioning to DOAC testing specifically, this just shows you the three anticoagulants, the three 10A inhibitors, right? Rivaroxaban, apixaban, and edoxaban, all quantified by mass spectrometry. And then when you run anti-10A assay, which you see on the right axis, or on the y-axis, excuse me, you can see there's a good distribution. So if your patient is not on any other anticoagulant, you can see a positive effect. But of course, the concentrations are well beyond the therapeutic window. And you can see here for the anti-10A, excuse me, but you can see that the concentrations of your drug can vary, going from all the way about to 400 nanograms per ml. And that's pretty significant. And that's where we think about, well, how do we adequately assess these patients? How do we adequately monitor these patients? Or, sorry, wrong word, how do we adequately measure these patients? So I like this because it kind of shows you the effect that these anticoagulants can have on your routine coag test. For example, if we're looking at a PT, INR, and APTT, you can see that in the respective of which anticoagulant you're using, it could be, if your PT INR is normal, it could be possibly present, or if it's abnormal, it could be likely present. So not very definitive answer on whether or not I do or don't have my anticoagulant on board. If I'm using the thrombin time, yes, even a small amount would cause a abnormal thrombin time of a direct thrombin inhibitor like dabigatran. But of course, it won't be relevant for my other assays, apixaban, rivaroxaban, and edoxaban. Interestingly, if I don't have any other anticoagulant on board, as I hope that previous slide shows you that if I have a less than 0.1 units per ml, if I'm just using a heparin or LMWH calibrated anti-10A assay, you can say that it's likely absent that I have an anti-10A inhibitor. But if it's greater than, it's likely present. But again, not very definitive. What's interesting though, if I use these special DOAC assays for the quantitative assessment, I won't focus too much on dabigatran because you would need either dilute thrombin time or Heparin clot time to assess these patients. But if you use specific DOAC calibrated anti-10A assays like apixaban, if it's greater than or less than 50 nanograms per ml, which is important because that's where we define whether or not the antidote that can be administered will be clinically effective, would allow you to give you a concentration. And numerous studies have shown that mass spec and these DOAC specific calibrated assays correlate very well with each other. This is a kind of a busy slide, and you'll see a lot of numbers here. And this is where it becomes the tricky part. Depending on the clinical indication, for example, let's just focus in on apixaban, irrespective of which dose is being given. What you can see here is for if it's given for non-valvular atrial fibrillation, there are different peak and trough concentrations, broad variability. I alluded to that there's a lot of intra and intra variability. And I guess if you see for VT prophylaxis, again, a number of peak and trough concentrations. But what's interesting here is if you're using a specific calibrated chromogenic anti-10A assay against the apixaban, it allows you to give you a concentration, and it gives you that concentration of at or 50. So a greater than 50 nanograms per ml allows the antidote to be clinically effective, allows it to properly reverse the anticoagulant effects attributed to the anticoagulant, in this particular case, apixaban. If though studies have shown that if that concentration, if your concentration of apixaban or anti-10A DOAC is below that 50, then it's clinically ineffective. So there's really no need. It doesn't add anything to the overall anticoagulant or the reversal of the anticoagulant effect. And that's where it becomes important for two reasons. One, patient care, right? Making sure that the patient is properly taken care of and whatever needs to be done to the patient is appropriately done. And two, it's cost, because the cost of these anticoagulants is very costly. So that either the patient has to pay for it, the insurance has to pay for it, whatever that, whoever has to pay for it is a significant cost associated. But it's also, I'm giving something that's very costly, but if it's not going to be effective, why do I give it? So assessing and being able to use these DOAC calibrated anti-10A assays is so critical to be able to give us that concentration. And you can see if we're using our routine PDs and PDT assays, you're really not going to get to that level of 50 that's going to be that clinical decision on whether or not to give or not give the antidote to. The same thing applies with the dabigatran, right? But in this case, you're using a different assay, using these dilute thrombin times or Heparin chromogenic assays, but again, they have specific dabigatran calibrators associated with them. So that's why it's important to be able to assess and give you that value for us to be able to properly administer the antidote if needed. And some real things to consider, especially if your lab is having these more difficult conversations with the clinical staff on how to improve patient care or how do we properly assess these patients who are being anticoagulated. First of all, it's having and opening up that discussion, right, with our pharmacy and the clinicians that are on the floors, getting their input, getting their unmet clinical needs. What are their challenges? What are they seeing? How can we improve? That fosters into that second bucket of proper laboratory communication. Proper laboratory communication. How do we get that information? Properly conveying that. And of course, that third bucket is really education. Fostering the education, talking about the clinical utility, showing the importance of these decisions that can be made, these different laboratory assays that are available, informing our clinical staff, these are the different assays, these are what these assays are intended to do, this is what they're measuring, this is what they're monitoring, and so on. So with that, I'd like to conclude, well, clinicians are more familiar with APT. Remember, it's that provider experience. This is one of the most unique challenges that I've had when I was a medical director, and I'm having, as well as having conversations with many sites around the country that want to convert and want to use the anti-10A assay, is how do we convince our clinicians that the APT is just as good, if not better, in patients that are being monitored for heparin, or in this case now, the DOAC calibrated anti-10A assays. When monitoring unfractionated and low molecular heparin, yes, anti-10A is the method of choice. But of course, if you're using heparin calibrated anti-10A, you should be cautious when assessing the presence or absence of a DOAC, right? Because we need to know, has the patient been on another anti-10A heparin or unfractionated? And that's why it's important to transition to using DOAC calibrated anti-10A assays. Yeah, perhaps APT is more readily available in most clinical laboratories, but again, transitioning and having that discussion on whether or not an alternative assay like the anti-10A assay, which is more versatile because it's able to not only monitor those patients that are on heparin, but can be transitioned using specific calibration curves or calibrators to monitoring those DOACs. And it really just ends up in education, education, education. I can't stress this enough, is really being able to communicate effectively. Here's what the lab has. Here are some of the advances that have been currently made. This is where we can access and what we can do today. And as I was reading through and preparing for some of this talk, I ran across this sentence in a paper. The uncomfortable marriage of convenience that is represented by unfractionated heparin and the APT will continue to endure and is unlikely to be terminated in the near future. I think that's a pretty impactful statement because it's the marriage of convenience. We have been accustomed to using one specific assay for a number of years now that doesn't allow us to see beyond some of those limitations that assay may have when we talk about patient care and anticoagulation. And with that, I'd want to thank everybody for your attention, and I would be more than happy to take any questions.
All right, well, thanks, Dr. Mitzios. We do have a little time left, so let's answer at least one or two of the questions that came in during the presentation. If you haven't already, please input your questions into the Q&A chat box. I don't think we'll have time necessarily to get to them, but the Siemens team will, and Dr. Mitzios will definitely respond to you directly after the fact. So we did have a question first question that came in is anti-10A an appropriate test for patients on bivalve?
So bivalve is a direct thrombin inhibitor. So most likely bivalve would not be prolonged in the context of anti-10A. So you would want to most likely revert to a different assay like a dilute thrombin time or that's calibrated against bivalirudin calibrators. But anti-10A probably would not be a good assay to assess that.
Okay, great. Well, Unfortunately, that's all the time we have today. I know a couple more questions have come in. Again, Dr. Mitzios and the Siemens team will answer those after the fact directly. But I would like to thank today's presenter, Dr. John Mitzios, for that very expansive and very thorough presentation on anti-10A assays. And I'd also like to thank the Siemens Healthineers team for sponsoring today's event. We couldn't have done it without you, so we really appreciate that. We will again send all those audience questions received today during the event to the Siemens Healthineers team. If you have any additional questions, please feel free to send them to me directly at webcasts@medcore.com. Also, please email me at webcast@medcore.com with comments, questions, and future webinar suggestions. We're always looking for great ideas, and we rely on our audience to help us come up with those. Visit us at clpmag.com and follow us on all of the major social media platforms. We do post fairly regularly there. So thank you again for taking the time to attend this CLP webinar.